Second white coat. Subscribe and like. Let's learn medicine together.
All right, let's dive right into this explainer. Today we're putting on our detective hats to tackle a classic clinical mystery step by step. You know the drill. We're building that board-style reasoning. We're going to break down the pathophysiology, toss out the distractors, and build you a rock-solid mental framework for glomerulonephritis.
Okay, so let's treat this question stem exactly like a crime scene. We're hunting for those pathognomonic clues to find our correct diagnosis from a lineup of the usual suspects. You know, minimal change disease, nephrolithiasis, PSGN, pyelonephritis, and rhabdomyolysis. Now pay close attention to the specifics here. We've got a 10-year-old boy. He rolls in with dark brown urine that conveniently started right after swimming practice. His blood pressure is sitting at 130/80, which is kind of high for a kid. He's got swelling around his eyes. And checking his labs, well, his creatine kinase, or CK, is totally normal, but his urinalysis, it shows something massive. Tons of red blood cells and RBC casts. So what exactly is going on with this kid?
Here's our roadmap for this case. First, the classic clinical stem. Then, finding the smoking gun. Next, eliminating the suspects. Fourth, unmasking the true culprit, PSGN. And finally, some ultimate board shortcuts. Let's jump into Section 1, the classic clinical stem, and deconstructing the clues. We're going to isolate the absolute key trigger phrases from this presentation. Check out this combination: a child with tea-colored urine, periorbital edema, and hypertension. When you see that specific triad, it should immediately fire off a specific neural pathway in your brain. Honestly, test writers use these exact trigger phrases over and over again. Your brain should basically flash a giant neon sign reading post-infectious glomerulonephritis, or PSGN, until proven otherwise. But hey, we're good detectives, right? We can't just guess. We need to know exactly why. And the reason the urine looks like this is absolutely crucial. That dark, smoky, tea or cola-colored urine, that is not bright red bleeding from the bladder or urethra. Bright red usually screams lower urinary tract, but that dark brown color tells us the bleeding is happening way high up in the kidney, right inside the glomerulus. The red blood cells literally get oxidized and broken down as they travel all the way through the nephron, which changes their color from red to that murky brown. Now, let's think about the mechanical consequences of that glomerular damage, like why the puffy eyes, why the high blood pressure? Well, when the glomeruli are inflamed, the kidneys just can't filter properly. They start hoarding salt and water. That extra fluid backs up and leaks into loose tissues, which gives us that classic periorbital edema, that puffiness around the eyes. It's a massive pediatric clue. And at the exact same time, the damaged kidneys are essentially freaking out, so they activate the RAS system. That RAS activation, combined with all that retained fluid, boom, that's what drives the blood pressure up. Moving right along to Section 2, finding the smoking gun, the absolute turning point. Every good medical mystery has a smoking gun, right? Well, ours is hiding right at the very end of the urinalysis. Here it is, the RBC cast. Seeing an RBC cast instantly branches your clinical reasoning pathway because it absolutely screams glomerulonephritis. Just think about how a cast actually forms. It's basically a microscopic mold of the kidney tubule. So for red blood cells to get squished together into a cylindrical mold, they had to have been forced through the glomerulus and straight into the tubule itself. You literally cannot get an RBC cast from bleeding in the ureter or the bladder. It's physical, structural proof that the bleeding is coming from inside an inflamed nephron. All right, Section 3, eliminating the suspects and avoiding the traps. Now that we have our smoking gun, let's interrogate the wrong answers and figure out exactly why the test writers threw them in there to begin with. First up, we can toss out minimal change disease. As you can see, this sits firmly in the nephrotic syndrome camp. It's a protein-leaking disease from podocyte damage, right? Massive proteinuria, low albumin, edema. But here's the catch. It completely lacks the hematuria and RBC cast you'd see in an inflammatory nephrotic syndrome. So even though our kid has edema, his dark urine and RBC cast definitively rule this out. Your quick mental shortcut: nephrotic is a protein problem, nephritic is a bleeding and inflammation problem. Next suspect, nephrolithiasis, or kidney stones. Now you might be thinking, well, stones cause bleeding, don't they? And yeah, for sure they do. But remember our simple rule? RBCs floating alone could just be a stone scraping up the ureter as it passes. But RBC casts, those guarantee the bleeding is inside the inflamed glomerulus. Plus, our patient doesn't have any severe flank pain shooting down to his groin, which is the classic hallmark of passing a stone. We can also easily cross off pyelonephritis. And the way we do this is by distinguishing between our microscopic casts. This is a super high-yield distinction, guys. White blood cell or WBC casts point to kidney infection and inflammation, which is pyelo. You'd also be looking for a fever, flank pain, and maybe positive nitrites on the dipstick. RBC casts, on the other hand, point straight to glomerulonephritis. Always match the specific cell type in the cast to the specific disease process. Okay, now for the rhabdomyolysis trap. Test writers absolutely love using the swimming practice detail to bait you into picking this. They want you to think, oh, heavy exercise, muscle breakdown, dark urine. And honestly, that's true. Rhabdo does cause myoglobinuria. But here's the trap. Myoglobin triggers a false positive on the urine dipstick for blood, but when you actually look under the microscope, 0 red blood cells. Our patient's microscopy showed tons of RBCs and those all-important casts. Plus, real rhabdo would show massively elevated CK from all that muscle damage, and our kid's CK was completely normal. Trap totally avoided.
Which brings us to Section 4, the true culprit, PSGN, unmasking post-infectious glomerulonephritis. We've cleared all the distractors, so we're left with the only logical diagnosis.
Our patient's presentation perfectly lines up with PSGN. This is your classic nephritic syndrome. On a cellular level, what's happening is that a couple of weeks after a strep infection, like strep throat or maybe impetigo, immune complexes form. These complexes deposit straight into the kidney's glomeruli. This triggers complement activation, which specifically causes uniquely low C3 levels, and it just unleashes an absolute storm of inflammation. That inflammation is what causes the bleeding, the casts, the fluid retention, and the high blood pressure. It all just ties together perfectly. Finally, Section 5, Ultimate Board Shortcuts and High-Yield Takeaways. Let's see how all this builds into a quick reference strategy for your exams. I highly recommend you just commit this high-yield table to memory. When you're racing the clock, matching the exact urine finding to the disease process is the absolute fastest way to confidently toss out wrong answers. If you see RBCs only, think stones or trauma. WBC casts, think kidney infection. Dipstick says blood, but the microscope says no, think rhabdo. Heavy protein but no blood, minimal change disease. And if you see RBC casts, well, you know exactly what that means. Which brings us to the ultimate board shortcut. Look, if you only take one single thing away from this explainer, let it be this unshakable association. RBC casts equal glomerulonephritis. Literally, every single time. The second you spot that in a question stem, you can immediately throw out stones, infections, and muscle breakdown, and laser focus straight onto things like PSGN, IgA nephropathy, or rapidly progressive glomerulonephritis. So, next time you come across a dark urine case on the wards or the boards, are you going to be tricked by the exercise history or the dipstick? Or are you going to be the detective who looks straight for the cast? I really hope this structural breakdown makes your clinical reasoning sharper, faster, and just way more confident. Keep interrogating those question stems, and I'll catch you next time.